Hi, I'm Dr. Pasek. I'm a physical medicine and rehabilitation physician as well as sports medicine and interventional spine, and I'll be talking today about musculoskeletal medicine. I have no financial disclosures. These are the learning objectives. So I like to approach the musculoskeletal exam using this mnemonic. I think that it gives us a great structure to ensure you get all of the pertinent information from your patient. When you're asking about the location of the pain, the S, site of pain, ask the patient to show you with one finger where they have the most severe pain. If they can't, ask them to trace the pain with one finger. When you ask about onset, it's how it started, when it started. Is it an acute or a chronic problem? Did it start yesterday or a year ago? Was the onset gradual or rapid? Was there an inciting event? Have they had this in the past? Asking about the character of the pain gives you information if the pain is musculoskeletal or neurogenic. Sharp burning pain is likely to be neurogenic. Radiating pain can give you information if the patient's hip pain, for example, originates in the hip joint or the spine. Pain that radiates below the knee is often from the spine, whereas pain that stays above the knee is often due to the hip or buttock region, such as the sacroiliac joint and ligaments. Asking about associated symptoms, this is when we clarify if there's any weakness or swelling. If you're asking about back pain, this is where we ask those red flag signs about bowel or bladder changes, saddle anesthesia, which is numbness between their legs, or foot drop when they can't walk, when they can't lift their foot when they're walking. By the way, if they have any of those red flag symptoms, that's a quick trip to the emergency room where they can have a spine surgical consult. Asking about time, duration of pain, is the pain constant or does it come and go? And this leads nicely into the next question, which is exacerbating or relieving factors. I like to start with a question, what makes the pain worse? Because sometimes when you ask what makes it better, they say nothing. Ask if the pain is worse at certain times of the day or with movements or certain positions. This is also the time to ask what treatments they've tried and whether they've experienced any relief. Severity is usually based on a numeric pain rating scale of 0 or 1 to 10, with 10 being the worst pain and 0 being no pain. Ask them what their current pain level is and what their worst pain in the past week. And also make sure you tell the patient how they're grading the scale. 0 is no pain, 10 is awful, period. Of all of these questions, the most important questions are site of pain and onset. With those two alone, you can really narrow down your differential. Case 1, shoulder pain. Mr. Powers is a 73-year-old man who we've known for about 3 years. He has hypertension and a hyperlipidemia. He is on aspirin, a multivitamin, hydrochlorothiazide, and simvastatin. He's retired and enjoys reading, babysitting his grandchildren, and occasional gardening. He also walks about 30 minutes 5 times per week. Mr. Powers comes to see you today for a routine checkup but complains of right shoulder pain. So what questions would you ask Mr. Powers? When we ask, we'll go back to that Socrates mnemonic. When asking about weakness, it is important and sometimes impossible to ask the patient if they are having any weakness secondary to the pain or if it's weakness that is because they can't do it. Could he use his shoulder if he really had to, even if he was having a lot of pain? Also ask what medications he has tried, if he's had any injections, trauma, i.e. a fall on an outstretched hand, or a fall against a house. So in his case, has he had any history of trauma? Has he had any recent repetitive stress moves, such as with some of his hobbies? Is he right-handed or left-handed? Ask about his occupation and hobbies. How has this affected his function? Is he able to comb his hair, wash his back, reach into cabinets? He is right-handed and describes the pain as starting about 1 month ago, but does not remember any initiating factors. Mr. Powers does not recall any specific time it started, but just noticed it one day. He describes the pain as 7 out of 10, dull and achy, and it does not radiate anywhere. It feels a little stiff, but feels worse as the day goes on, especially with trying to put his shirt or jacket on. He denies any effect on his activities of daily living. He's using more of his acetaminophen than usual and sometimes ibuprofen. Mr. Powers denies any recent trauma or falls. He also denies any warmth, redness, or swelling. We're going back to that Socrates mnemonic. The site was very nonspecific. The onset was about 1 month ago with no inciting event, no trauma or falls. The character of the pain is dull and aching with some stiffness. He does not have any radiating pain, nor warmth, redness, or swelling. The timing was not really applicable. It kind of was with gradual onset. The exacerbating factors, it's worse as the day goes on, worse with upper body dressing, in particular, putting on his shirt or jacket, and he's using more Tylenol and occasional ibuprofen, and the severity is a 7 out of 10. We don't have a specific location. Likely he put his hand over his entire shoulder. It is important to find out how he was taking the Tylenol and ibuprofen, the dose and frequency, and if it is helping. This will help us later when we are making treatment suggestions. Although occasional ibuprofen in an older person is likely not going to cause problems, we try to avoid having our older patients use it with any regularity due to risk of cardiac or renal complications. The next couple of slides are reviewing the anatomy and are for your review. This is a very nice image that shows how the location of the pain can identify and narrow down the differential. In all likelihood, the patients coming to your office will have chronic or subacute pain, and therefore we will focus on these types of injuries. If a person does come to your office with significant pain after a recent fall or trauma, they should be sent for imaging to rule out a fracture, usually of the proximal humerus. The most common chronic shoulder problems in the geriatric population are by far rotator cuff dysfunction. This is an umbrella term that includes subacromial, subdeltoid bursitis, rotator cuff tendinopathy, and partial and full thickness rotator cuff tears that can often be degenerative in nature. Other common shoulder problems are impingement, acromioclavicular joint osteoarthritis, adhesive capsulitis, which is also known as frozen shoulder. Less common but not to be missed are rheumatoid arthritis and Milwaukee shoulder, which is calcium phosphate crystalline arthropathy. Also paying attention if he's got any neck pain, because there may be some cervical radiculopathy with radiating pain into the shoulder. You can pay attention to hallmark signs because these can be helpful. Pain that increases at night may be due to rotator cuff dysfunction or glenohumeral joint arthritis in the side of the shoulder and the lateral shoulder, and it makes it hard to sleep on that shoulder at night. Here's another anatomy slide for your review. And this is using the SITS mnemonic to remember the tendons involved with the rotator cuff, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So you're going to start the physical exam. As we can see on the anterior shoulder, sometimes the location isn't enough information. This is when our physical exam is critical to helping differentiate the source of the pain. And yes, I have another mnemonic for the physical exam. So this is the IPROM MRSPS. So we always start with inspection. We're looking for symmetry, atrophy, swelling. For example, in cases of rotator cuff tendinopathy, there may be atrophy of the supraspinatus muscle. Palpation is usually next. We're looking for areas of tenderness or tightness. Range of motion, both active and passive. Can the patient move their limb through the normal range of motion? Are they limited in any direction? If they are limited in active range of motion, do they have greater passive range of motion? Motor strength. It's important to assess if the strength is symmetrical. and you're looking for subtle weaknesses in the symmetry or lack thereof. Reflexes, sensation, pulses. We're not going to focus on these for the sake of time. Again, you focus on symmetry. So if somebody is hyporeflexic on one side, are they hyporeflexic on the other side? Special tests for each joint aid in determining diagnosis. So for inspection, we're looking for symmetry, atrophy, swelling. When we palpate the shoulder, we usually start on the anterior aspect. Everyone develops their own technique. Palpating the clavicle to the acromion to the AC joint, then down a little bit to the subacromial, subdeltoid bursa, and then to the greater tubercle of the humerus, the bicipital groove. Usually start at the medial end of the clavicle at the sternoclavicular joint, and then you palpate laterally to the AC joint. And then from there, you drop into the space just distal to the AC joint. This is the subacromial subdeltoid bursa and can be very tender if there's bursitis. You palpate the bicipital groove to determine if there's any tenderness of the long head of the biceps tendon. When having the patient do range of motion, watch for whole body movements they may use to compensate for limited active range of motion. External and internal rotation can be done by asking the patient to touch their back, and external rotation can be assessed if they touch the back of their head at their occiput. When they do these movements, is the movement fluid? Does the movement cause pain? Is there any crepitus or clicking with the motion? Any problems with active abduction may indicate rotator cuff tears. Looking at special and provocative maneuvers, probably everyone remembers the empty can from medical school. This is specifically a test for supraspinatus tendinopathy with the arm in forward flexion with 30 degrees of horizontal abduction to bring it in line with the scapular plane. The patient's thumb is point down, and the practitioner resists the patient's upward movement. If there is pain, this is a positive exam. The drop arm test is when the patient cannot hold their arm at 45 degrees of shoulder abduction. A positive test usually means there's a large supraspinatus tear. And then we have Hawkins and Neers. Hawkins, the shoulder and the elbow are flexed to 90 degrees. The shoulder is in the scapular plane, similar to the drop arm test and the empty can. The practitioner internally rotates the humerus, and if there is pain in the AC joint, this is positive for impingement. The Neers exam, the arm is in forward flexion with the thumb down, and the practitioner applies pain by moving the arm up. The exam is positive if there is pain in the AC joint. So your physical exam suggests an impingement syndrome. The picture on the right is showing you the bursa, and as the arm is abducted, the bursa gets pinched and can be very painful. The bursitis, the impingement syndrome is when the soft tissue in the area is irritated. The subacromial subdeltoid bursa may be inflamed, and there is often rotator cuff tendinopathy with degenerative partial or full thickness tears. What else is in the differential diagnosis? Rotator cuff tear that we've talked about. You'll see weakness of the muscles. Frozen shoulder, which is a decrease of movement in all motions, in all planes. They may have osteoarthritis of the glenohumeral joint, and that's pain with active range of motion and also can be seen on imaging. And cervical radiculopathy is associated with neck pain with paresthesias and possible weakness radiating into one or both of the arms. The special test to assess for cervical radiculopathy is the Sperling test. Would you perform any diagnostic tests? If you suspect bony abnormality, you can order a shoulder X-ray with AP and axillary views. A complete tear of the rotator cuff may have a high-riding humerus seen on X-ray. If you're suspicious of rotator cuff pathology or any soft tissue pathology that is refractory to conservative management, you may want to order an MRI to determine if they would benefit from an injection or surgery. So how would you treat this patient with impingement syndrome? Primarily pain control and gentle stretching. The sleeper stretch and pendulum are shown here, and these are exercises the patient can do at home. Pain control is very important, and scheduled Tylenol, 1,000 milligrams 3 times a day for 1 or 2 weeks can be used to see if that helps with the pain. Topical medications just over the counter can also be helpful, such as diclofenac or topical lidocaine. So there's 3 stages for the rehabilitation. There's stretching, and you can use heat before stretching. You stretch to the tightness, but not through the pain. And you hold and breathe until that tightness dissipates and then can increase the stretch. You do want to attain almost full range of motion before moving on to strengthening. With strengthening, even just a can of soup or very light weights can be very effective. So in this example, the patient has the weight with their thumb down and they're doing small movements of abduction. Again, with the strengthening, just starting with very light weights is important, starting with just small repetitions. I often just have people weave these exercises into their day so that they can not have to set aside specific time, but repeat these exercises several times throughout the day. And then after increasing range of motion and strengthening, increasing the intensity and the duration will be important. So this patient has done his home exercises and has had a steroid injection and is not necessarily improving. So would you refer to a physical therapist or occupational therapist? It gets a little bit confusing. Generally, we have occupational therapy if there are problems with the upper extremities or if there's problems with activities of daily living. And the physical therapist will usually work with the patient for shoulder pain, neck pain, and other issues, such as working with large muscle groups, strengthening, ambulation training. Yeah. Okay, so now we're on to case 2, which is knee pain. Mr. Bernard is a 78-year-old man with a past medical history of hypertension, glaucoma, congestive heart failure, chronic renal insufficiency, and bilateral osteoarthritis of the knees. He presents today for follow-up and complains that he can't walk to the corner to play cards with his friends because his right knee hurts too much. What would you do for him? Again, I have this picture for review so that you can look at the location of the pain and see some of the diagnoses associated with that location of the pain. And a review of the knee anatomy. So taking a history, what questions would we ask Mr. Bernard about his chief complaint? Where is the location of his pain? Is it on the anterior, which would lead us to think of the quadriceps or patella? On the medial aspect, perhaps a medial meniscus tear, maybe a medial collateral ligament tear. There could be pes anserine bursa pain. On the lateral aspect, we have the lateral meniscus or the lateral collateral ligament, also the IT band. And in the back, it may be a popliteal cyst. So we're going to just remember that Socrates acronym. So anterior knee pain is often associated with chondromalacia patella. Pain along the quadriceps or patellar tendons is likely tendinopathy and possibly a partial tear. Medial knee pain at the joint line is often a torn meniscus. Pain in this area may also be related to medial compartment osteoarthritis. Lateral knee pain is often due to iliotibial band syndrome. Pain along the lateral joint line, like the medial joint line may be due to a lateral meniscus tear and or lateral compartment osteoarthritis. Posterior knee pain may be due to a Baker's cyst. A knee effusion also can put pressure on the back of the knee when they're with knee flexion. A popliteal aneurysm is a very uncommon cause of posterior knee pain, but good to be aware of it. So part of the history is, now we're on, when did it start? What is the quality of the pain? Has there been any swelling? If it's acute and there's swelling, there may be hemarthrosis. Chronic swelling may be due to arthritis. Does the knee lock? Then we're going to be thinking about a meniscus tear. Is the pain constant or does it come and go? What makes the pain worse? Have they tried any treatments? Has the treatments helped with the pain? How severe is the pain? How much does the pain interfere with the quality of their life and their ability to function and walk? The most common knee problems that are chronic are osteoarthritis, bursitis, and meniscus tears. And meniscus tears are often degenerative in the older population. You begin your physical exam, and again, we remember that mnemonic. That starts with inspection. We're looking for the alignment of the patella, any swelling or erythema, any bony changes. We palpate the front along the quad tendon and the patella and patellar tendon, the medial and lateral joint lines, medial and lateral collateral ligaments, pes anserinus, the popliteal space, looking to see if they have a Baker's cyst, and any knee effusions. If there's pain over the patella, you consider prepatellar bursitis. And if you're palpating the patellar tendon and there's pain, you are going to be thinking about a tendinopathy. You continue into the tibial tuberosity, which is where the patellar tendon inserts, in order to fully examine this part of the body. We look at range of motion of the knee in flexion and extension. When passively flexing the knee, you palpate for crepitus, which is a sign of osteoarthritis. Limited and painful range of motion in flexion and extension may be due to an effusion and or osteoarthritis. If there is locking or catching with flexion and extension, consider a meniscus tear. Special maneuvers. Some of the most important ones are the McMurray test, which is an easy way to test for meniscal involvement. After a passive flexion of the knee, an extension of the knee is done by the practitioner. Turn the heel medial, flex and extend the knee, and if there's any pain or clicking, then it may indicate a medial meniscus. Turn the heel lateral, and you can flex, extend the knee. Any painful clicking or locking is positive for lateral meniscus involvement. Joint line tenderness is usually due to either meniscal tear and or osteoarthritis. Your physical exam suggests osteoarthritis at the right knee. He has pain and difficulty with ambulation and stairs, decreased joint range of motion, knee buckling, muscle atrophy, and antalgic gait. How would you treat this patient? So there's always the discussion of anti-inflammatories versus acetaminophen. Osteoarthritis is not an inflammatory arthritis. Acetaminophen is effective in treating osteoarthritis pain and does not have the same GI side effects nor other complications associated with NSAIDs in an older person, period. You also want to consider doing home exercises, physical therapy, possibly bracing, and maybe they need a straight cane to help them with balance and improved walking. There is no role for opioids in chronic osteoarthritis. Tylenol usually is adequate. Topical pain control is often very helpful. Voltaren gel can be very effective, especially if used 3 to 4 times a day for several days, and lidocaine cream or patches. If there is pain refractory to these conservative measures, consider doing an intra-articular steroid injection. Strengthening the quadriceps and hamstring muscles is important for stability, decreasing pain, and improving ambulation. Exercises such as sitting, straight leg raises, and standing hamstring curls are easy to do and can be done throughout the day. These can be given as home exercises or prescribed as part of a physical therapy prescription. Heat and ice are easy to use modalities that also can be done at home or during formal physical therapy. Aquatherapy is a good exercise option since it is less painful than walking on land while strengthening the muscles, and I often recommend this to my patients when they have resistance to doing home exercises because of the pain. I ask them to find a pool if it's possible and do their exercises and walking in the pool. So we can also consider injections. I mentioned steroids before. Hyaluronic acid is often very helpful for patients, and they both can provide pain relief that will allow full and active participation in physical therapy. I do like to hold off on steroids when possible. I'll usually do a steroid injection initially just to see that they're getting pain relief. And if they get some pain relief from that, I'll often move on to doing a series of hyaluronic acid injections. And there are other injections that can be very helpful for knee pain due to osteoarthritis. So when does somebody need surgery for osteoarthritis? The decision to do surgery is primarily when their quality of life is significantly impaired, when they're having pain at rest, when they're having pain that interferes with their sleep, significant limitations in walking, and if they aren't able to do the things that they love with the people they care about. So using a cane is not intuitive. First, you have to have the cane measured correctly. The top of the cane should be at the level of the greater trochanter. This will put the elbow at approximately 30 degrees. The cane should be held contralateral to the knee or hip pain. Canes offload the painful joint to make ambulation easier and widens the base of support for improved balance. The cane in the contralateral hand should be advanced at the same time as the painful side. Going downstairs, the painful side leads. Going upstairs, the unaffected side leads. And now we are on case 3 for hip pain. Ms. Matos is a 77-year-old woman who lives alone in an apartment building whom we have known for 7 years. She is obese, has osteoarthritis, type 2 diabetes, coronary artery disease, and hypertension. Her medications are aspirin, hydrochlorothiazide, glucophage, acetaminophen, atenolol, and lisinopril. At your last visit, you prescribed a general exercise program for her. At her follow-up appointment at 1 month, she had no complaints after starting the exercise program you prescribed. She also reports how much she enjoys doing the exercises. It is now 2 months since she started the program, and Ms. Matos is on your patient care schedule this morning. She has a chief complaint of, my right hip arthritis is acting up. Again, I love this image for helping us with our differential diagnosis. The location of the pain is so important when we're talking to our patients. Just a review of the anatomy. On the right side, the blue are the bursa in the hip area. We see that there are many bursa, and so it's a misnomer to say greater trochanter bursitis. It's really greater trochanteric pain syndrome, because each of these bursa can get irritated and cause pain, and also pain in this area is often due to gluteal tendinopathy. So what questions would you ask Ms. Matos about her chief complaint? Where is the pain? Describe the pain. Does it radiate? Is it going down below her knee? Any pain in her back or below? Any stiffness? Any warmth or redness? Any swelling? Any limitations in her range of motion? Again, this is the Socrates mnemonic. Has she had any recent falls or trauma Has her gait changed? Has she changed her exercise program? Does she take any medicine for the pain? And how severe is the pain? She describes the pain as starting about 2 weeks ago, but does not remember any initiating factors. Ms. Matos recalls waking up and feeling the pain in the morning after walking. She describes the pain as 4 out of 10, dull and achy, and it extends down the thigh. It feels a little stiff, but does not feel better as the day goes on. It actually might feel worse, but she has limited her walking because of the pain and is depending on her cane for more support. She is using more acetaminophen than usual. She denies any trauma or falls. She also denies warmth, redness, or swelling. So a summary of her history. She has hip and thigh pain that started about 2 weeks ago, about 6 weeks after starting a general exercise program. The pain is dull, aching, and stiff that travels down her thigh with no warmth, redness, or swelling. The pain is worse with walking and better with her cane and Tylenol and is about a 4 out of 10. So we'll move on to the physical exam. Again, looking for any swelling or asymmetry during the inspection piece, palpating the ischium and the greater trochanter, as well as the iliac crest. When you're palpating the back, when you're palpating the hip, always include the back. We look at the range of motion, flexion, extension, abduction, adduction, internal rotation, and external rotation. In hip osteoarthritis, internal rotation decreases before external rotation. Abduction and adduction can be assessed when doing Faber and Fadir, which we will see in an upcoming slide. Always watch a patient walk. Observe their arm swing, their stride length, their stride width. Observe their posture. Are they antalgic when they're walking? The physical exam special tests, we're looking at the slump test to assess for radicular pain, Faber and Fadir, and the log roll. The slump test is a quick and easy way to assess if the hip pain is actually coming from nerve root irritation. Faber or Favier stands for flexion, abduction, and external rotation. If there is pain in the back with this maneuver, consider the sacroiliac joint as the pain generator. If there is pain in the groin, it is likely hip pathology. Fadir stands for flexion, adduction, and internal rotation, and the log roll assesses for intra-articular hip pathology. Your physical exam suggests greater trochanteric pain syndrome, but what else is in your differential diagnosis? There could be osteoarthritis of the hip, and we would see that with a loss of internal rotation. There could be lumbosacral radiculopathy, and this would be with paresthesias radiating down the leg. A trochanteric fracture, we would hopefully see that on x-ray, and we would see a severely antalgic gait. And there may be a tumor along with constitutional symptoms, including weight loss and night sweats. Would you perform any diagnostic tests? Generally speaking, you would want to have a hip x-ray. Usually you'll see arthritis, but you may see other pathology. You'll get an AP pelvis and lateral hip x-rays. And if you were concerned about any soft tissue issues or cancer, you could order an MRI or a bone scan. Pain control, again, is very important. Most pain can be controlled with scheduled Tylenol or using Tylenol prior to doing an event or activity that would cause pain. One can do a steroid injection if no response to the initial interventions. Avoid sleeping on that side and doing home exercises and physical therapy. Topical pain medications are worth a try, but may be limited in their efficacy due to the depth of the hip and some of the other structures. I think it's always worth a try because it may give some people relief. How would you treat this patient? You can apply ice to the area 15 minutes every hour. Limit the activities, but not complete rest. Unload weight bearing, such as using the cane. And then once you've got your pain controlled, you could move on to some other treatments. If they have very severe pain that's interfering with their quality of life and their ability to participate in physical therapy or doing home exercises, you can consider doing a steroid injection. There are some complications associated with steroid injections. If you inject steroid into a tendon, there's a risk of rupture. You can have steroid arthropathy, which is rapid destruction of the joint with multiple injections. This is a very controversial topic, but it is worth knowing that it is a possibility. I think that steroid injections are most beneficial when the pain is interfering with their ability to do the exercises that we've prescribed, or if they have an event coming up that they want to participate in, such as a walking trip through Scotland or a wedding that they want to dance at. Again, there are some complications associated with a steroid injection, skin changes such as depigmentation or scarring. There's always a risk of an infection whenever we do an injection, and you can have periarticular calcifications. So the pain control would allow this person to do more of the home exercises, such as stretching the iliotibial band, the quadriceps, and the hamstrings. Once the pain is controlled, they also want to make sure that they're strengthening their hip abductors with the exercise on the bottom right picture. So in summary, most of the patients coming to your office will have chronic musculoskeletal complaints. Acute injuries usually require imaging to assess for fracture, although often imaging is done even with chronic to assess for the severity of arthritis or to see if there's anything else going on that we might identify on the image on the X-ray. Tylenol scheduled can reduce musculoskeletal pain without the same cardiovascular or GI risks as NSAIDs. And please remember Socrates and IPROM-MSRPS. These really can help guide your visit with a patient and get the most information. And if you aren't sure, or if it's complicated, please refer to physiatry, sports medicine, or orthopedic surgeon. We'll move on to the post-test quiz. What test assesses for rotator cuff dysfunction, specifically a supraspinatus tear? A, the Fulcan test, B, Hawkins, C, empty can, D, Nears. And the answer is C, the empty can test. I think this is the end of the lecture because the next slide is keywords. And then after that, it's my mnemonic for the history, and then my mnemonic for the physical exam. And these are my references. And this is my contact information. Good luck.